Welcome, everyone. Thank you for joining in this presentation entitled Addressing Tobacco-Related Inequities Among Latinx and Hispanic Community. The creation of this presentation is part of the Taking Texas Tobacco-Free Project initiative to disseminate information that is relevant to the needs of different vulnerable groups. Sharing my presentation with you here today. Okay, so a little bit about myself. I'm Dr. Birmari Correa Fernandez. I'm an associate professor at the University of Houston and also the director of the Latino and Behavioral Health Research Team. I am a clinical psychologist by training, a tobacco treatment specialist, and have been working in the tobacco control field for more than 19 years. My main research emphasis is in understanding the determinants of smoking and cessation among Latinx groups and Hispanics, and developing and testing culturally competent smoking cessation interventions for these groups. So the information I'm going to share with you today is an integration of where the research is in the field, including my own, and the clinical experience that back this up. So an overview of the presentation. First, I want to talk about definitions of the Hispanic Latinx community, then the prevalence and patterns of tobacco use, what are the main tobacco-related inequities in our population, potential causes of tobacco-related inequities, culturally relevant tobacco use screening and intervention considerations, and we'll share some additional resources with you. So first, who is the Hispanic or Latinx community? These people are defined by persons, or this concept is defined by persons of Cuban, Mexican, Puerto Rican, South and Central American, or other Spanish culture or origin, regardless of race. This is important to notice because even though we may think about Latinos as brown people, there are people that are Black, are white, they're mixed. So in reality, like 2/3 of the population in the Latino community don't see race and ethnicity separate, but they see them as something together. So you will encounter a lot of people that finding this, that is not typical to think about race and ethnicity for their Hispanic background. The term Hispanic particularly refers to the people who speak Spanish or the descendants from Spanish-speaking populations. So this Hispanic is more about language. On the other hand, Latino, Latina, or Latinx, which is the gender-neutral term, refers more to people with Latin American origins, regardless of their preferred language. So Hispanic is more language, Latino, Latina, Latinx is more about geography. In general, I feel like the community seems to self-identify more with the term Latino more than Hispanic. Hispanic was initially used in the census a few decades ago, but it's more like a governmental term that was used for the population. But we may prefer Latino in general more, but that both are well accepted, and the preference differs geographically as well. The Hispanic Latinx community comprises about 18% of the US population nowadays, and is expected to grow to about 30% by 2060. This means that the health of this population is really important for the health of the nation as a whole. So why to address tobacco-related inequities among this population? First, smoking is linked to the two major causes of death in the Hispanic Latin population: cancer, heart disease, and the third cause among women. So among female and male, both cancer and heart disease are number one cause of death. And then the third one among women, which is stroke. The three of them are related to smoking. Also, Hispanic Latinx individuals experience excess mortality due to various forms of cancer, including cervical, liver, and stomach. In terms of cancer in general, cancer is the first and now is the leading cause of death for this population, with the chances of approximately 30% of Hispanic or Latinx men and women, to be diagnosed with cancer at some stage in their lifespan. And this is a very high percent. So the first step to understand and address tobacco-related inequities among this population is to know about the prevalence and patterns of tobacco use. What I'm going to do in the next few slides is to present you a question related to prevalence and patterns, and I will stop for a few seconds just to give you a chance to see if you know the answer to those questions. Let's see how that goes. So the first one, what percentage of Hispanic Latinx in the United States smoke conventional cigarettes? 8%. You may have chosen a higher percent, and that was true more than a couple of years ago, but during the last year it's just 8%, which definitely is good when we take the Hispanic community as a homogeneous group and the overall percent. But we have noticed that the percent per different ethnic groups or sub-ethnic groups is different. So which ones, if you know, what Hispanic or Latinx subgroup has a higher prevalence of smoking? Mexicans, people from the Caribbean, people from Central South America, or it's just the same across subgroups? Caribbean. And within the Caribbean, we're talking about Puerto Ricans and Cubans have the higher rates among all the other subgroups. This is a graph a few years ago representing that Puerto Ricans smoke at more than 25%, followed by Cubans, then Mexicans, and then Central South American. Dominicans, even though they're not in this graph, but they smoke at lower rates, probably one of the lowest rates. Dominicans are one of the groups that have lower rates of smoking. And these percents have been going down, fortunately, but still the Puerto Ricans and Cubans smoke at very high rates, and including daily smoking, levels of dependence, cigarettes per day, all those characteristics are higher among these two groups. Okay, next question. In which of these Hispanic Latin subgroups the prevalence of cigarette smoking is higher? US-born Latinx, foreign-born Latinx, is the same among both, or is just unknown? US-born Latinx. So potentially contradictory to what we think, or we may used to think, people born in the US smoke at higher rates and have higher prevalence of smoking than their counterparts in their country of origin. Also, what are the typical patterns of smoking among Hispanic and Latinx? What do we know about if they are light smokers, which means people that smoke less than 10 cigarettes a day? Are they intermittent or non-daily smokers, meaning that they do not smoke every day, but just occasionally? Are they heavy smokers, meaning that they smoke 1 pack or more a day and likely every day? A combination of being light and intermittent smokers, or all of them are true? Give you 1 second. And if you chose light and intermittent smokers, you're correct. The typical pattern of smoking among Hispanic and Latinx is that they smoke not every day, but intermittently, and they smoke less than 20, or according to the definition of light, like less than 10 cigarettes a day. That doesn't mean that all Hispanics smoke that way, but it's very typical pattern, or more common than probably other populations. So that's something else to note. And these intermittent and non-daily are the terms that we use in the literature, but the actual person, the Latinx person, they usually use terms like social or occasional. So you will hear these terms, but in our literature, we refer to that as intermittent and non-daily. Also, what do you know about cultural contextual factors that influence smoking behavior and quitting rates among Hispanic or Latinx groups? Are these important? So first, acculturation and enculturation are, yes, in general, contextual factors, cultural factors are important in smoking behavior and quitting. In both processes, this is like phases of the quitting process, right? Acculturation is that process to which or in which the person go into a new or host culture, embrace the behaviors, the traditions of the host culture. That's the acculturation process. And sometimes it's thought that this is a unilateral process, but like meaning that the person just go and acquire the traditions, the culture, the thoughts, the behaviors of the host culture. But the reality is not that way. It's not that simple. The term enculturation, on the other hand, is about how much of the previous culture or the home country culture the person maintains, the extent to which they maintain their own traditions. And we have seen in the acculturation literature beyond smoking that this process goes hand in hand, and people do not have to choose one versus the other. Some people just focus on their acculturation process and leave behind their origins or their roots, but some people embrace both cultures, and that's the biculturalism term, right? So what we have found that acculturation, more smoking behavior, and that's also different by men and women, and that acculturation could be a protective factor for some of these folks to continue smoking. So it could be a good factor to quit smoking. So the relationship is very complex. It's not as easy, and this also may vary by these sub-national groups that I mentioned, of different groups of Hispanics. So it's not a very straightforward relationship, but we need to know that these factors are real and are important to take into consideration when we are trying to address disparities among these groups. Acculturative stress is just that this stress and that comes as part of getting into contact with a different culture and all that it takes. It's not surprise, right, that the immigration policies for Latinos are similar to other groups potentially, but very specific for Latinos are very distressful for the population, and that carries a lot of stress, not only the immigration policies, but even the process by itself. So all the acculturative stress or minority stress, it's an important factor to consider when we are assessing someone and we are trying to help them quit. And also discrimination. There's some research backing up and linking discrimination to lower cessation rates. This has been found in different cultures or different race and ethnic groups. But for Latinos in particular, we have found that major discrimination events, especially the accumulation of major discrimination events, it's linked to lower cessation rates. So these are some of cultural factors that have some research sustaining their relationships. This is kind of a summary, an image from the Truth Initiative, and have a summary of some of the things I have just mentioned. Basically, Puerto Ricans are one of the sub-ethnic groups that has higher rate of smoking. Dominican and Central South American have the lowest. People born in the US have higher prevalence compared to people not born in the US. Men has higher rates compared to women. And then research shows a link between acculturation to the US and increased smoking prevalence. So when we look at youth, here this graph also from the Truth Initiative and depicting data from the National Youth Tobacco Survey, the 2009 cohort, shows the difference between smoking versus e-cigarette among Hispanic, Latinos, middle and high schoolers. So we look at the first part, the high schoolers have a 3.8% of smoking, but a 23.2% of e-cigarette use. This is only Latinos, right? Then for middle school, 3.1% have smoking rates, but 13% e-cigarette use. So we see that the e-cigarette use is the preferred tobacco product or the most prevalent tobacco product among middle schoolers and high schoolers. You may be wondering, how does this compare with people from like the general population? So here we have the data from the same cohort and the same survey. For the general population in high school, they smoke at 5.8% rate, or not rate, but the prevalence is 5.8, but 27.5 e-cigarette use. So for the general population in high school is higher than Hispanics. But in middle school is the other way around. For middle school children, 2.3% cigarette smoking among the general population versus 3% for Hispanics, and 10.5 e-cigarette use in the general population versus 13 in Hispanics. So what we're seeing is that people like Hispanics that are younger age are starting to exhibit more e-cigarette use and smoking than the general population of kids of their same age. That's another disparity and a trend that we need to be vigilant about. Okay, so the first smoking prevalence varies among national groups as the first tobacco related inequity among Hispanics. I already mentioned that. So there's difference between subgroups. It's important to pay attention to the groups that have higher prevalence. No, it's important to notice that no smoking or no quantity of smoking is healthy or is safe. So we should not diminish or minimize the impact that can have on those groups that smoke less. But definitely we want to put more attention to the ones that smoke the most. But definitely attending and trying to serve everybody and not dismiss their consumption. Another of the important inequities is that predictors of cessation are unclear. That means that we don't know exactly, based on research, what factors are helping Latinos quit smoking or that are an impediment for them to quit. Of course, there's some research on the area, but it's not enough and it's still just growing. During the last decade, probably has been more research around than before. So we still do not know exactly what helped Latinos quit. We have some research about anxiety sensitivity. Depression on the other side does not predict quitting as much in Latinos as other groups. The difference between genders is also different than other populations. So there's more research that needs to happen to be able to determine in a more definite manner what helped Latinos quit. This is an important one, the limited use of cessation aids. People from Hispanic, Latinx backgrounds do not tend to use counseling or medication or nicotine replacement therapy. So their use of these aids is limited, meaning that they are not accessing what is evidence-based or what is empirically based. And there's a gap there in their use of things that really will help them quit. So they're struggling on their own, technically. Also, unfortunately, they're less likely to receive cessation assistance in routine health encounters. That means that there have been some research documenting that even in a regular health encounter, Latinos are less likely than white counterparts to be asked about their smoking history, and they are not offered the assistance that they need. So there might be an issue there about offering what these people need. So the access is not equal. Also, there's limited data on the efficacy of behavioral and pharmacological cessation interventions. We don't have a lot of information about what treatments work best with this population. Fortunately, there have been some, as I mentioned, in the last decade, and the amount of data is increasing, but we still have a long way to go. So as you can see, the main inequities related to tobacco related disparities are linked to treatment access and efficacy. So there's a lot to do in the area of service. Some of the promising approaches for smoking cessation among this population start with the clinical practice guideline. This guideline was created in 2008 and is still what we use as tobacco treatment specialists for the treatment of this population. And most of the information in this guideline is based on cognitive behavioral therapy. Also, the combination of counseling and nicotine replacement therapy has shown some evidence of good results and promising results. Other approaches that have shown promising results are motivational interviewing, acceptance and commitment therapy, including some of my own research and research using web-based interventions, and approaches that have culturally relevant components. In terms of modalities, in-person group-based interventions, phone-based, text-based, and also web-based interventions have some promising results for Hispanics similar to other populations. So this is encouraging, but again, we need a lot more replication of findings to really be able to know what modality is best for this population and what type of therapeutic approaches are better for this population. So potential reasons for inequities, why this may be happening. It's important to notice that these inequities are, of course, very complex. These are multi-level, multifactorial, so pinpointing only one reason will be simplifying the situation. And here I'm just providing a few options to think about. First, consider Hispanic Latinx as an homogeneous group, obscuring the needs of subgroups. I mentioned before, if we consider Hispanic as an homogeneous group, we look at 8% of prevalence, so then it'd be like, oh, who needs or why they need a treatment and service if they just smoke at very lower rates. Let's pay attention to other groups that smoke at higher rates. Hey, but if we disaggregate this and look at them as subgroups, we may notice that some of these subgroups smoke at higher rates than even the general population. So definitely one of the reasons of the inequities is that we have overlooked at the needs of subgroups. The lack of consideration of contextual factors. Mentioned migration-related distress, family separation, which definitely will increase their distress, acculturative stress, low socioeconomic status, or any financial burden, and lower education or lower unemployment or subemployment, or having many jobs to be able to get a decent living. All these are socioeconomic factors that may play a role. Also, lack or insufficient health insurance. We know there's some research showing that Latinos in general have less insurance or have less insurance than their white, non-Hispanic white counterparts. Other factors are related to tobacco literacy among the population. This is not unique to Latinos, but it may apply to Latinos as well. Something as simple as knowing that, or not knowing there in some situations, that nicotine is not the component that causes cancer or other health disease. And because they may not want to use nicotine patches because nicotine patch has nicotine, and if nicotine causes cancer, why I'm going to use a patch that has that? So knowing exactly how this addiction works and how the medication works might be some of the things that this population needs to be able to embrace the treatments that are empirically supported. Also, we know there's insufficient healthcare professionals from the same ethnic group, or that they're simply culturally informed to be able to address the needs of this population. We all know that trust in our healthcare professional is very important, and feeling represented. So definitely representation matters. And in lack of vis-a-vis representation from people from their same ethnic groups, having people, healthcare professionals that can be sensitive to their needs and their culture, it could be something to narrow these gaps. And all important to notice is that Hispanic or Latinx are underrepresented in cancer prevention and control research. Unfortunately, they comprise only among 7% of the National Institute of Health funded studies in terms of cancer research participants. So there's a long way to go having representation of our population in research studies that are the ones who inform our practices. So what we can do, what are some culturally relevant tobacco use screening and intervention considerations? First, let's include tobacco-related discussions in all healthcare visits. As mentioned, this population may look for help in community health centers or low-cost health clinics. And so it's important that this information about tobacco use assessments are embedded in any of these clinics or any of these centers. Even asking about people's tobacco status is important. I'm surprised, or was surprised many times when we ask these participants, have any of your doctors ask you if you smoke? And surprisingly, so many times that the answer is no. That's very disappointing, to say the least. But fortunately, these things have been changing. So there's a trend toward improving these health encounters, and we want to continue that trend and improve the interaction with clients. Also, I want to highlight respect or even avoid labels. What do I mean by this? First, people may differ in the way they want others to refer to them. If labeling them Hispanic, as Latinx, Latino, Latina, or maybe not even any of those terms. Some people were born in the United States, have been here for the whole lives, and may not even identify themselves with any of these labels or have a different label. So assuming someone's ethnicity by the way they look or the way they speak can create barriers in that communication. Sometimes we may want to make small talk about, I like your accent, or where are you from, where are you originally from? But those messages can be well taken by some, but may not be well taken by others, who may feel that those questions or those comments mean they are a stranger, they are not from here, they do not belong. So basically, be careful about the labels that we use and the assumptions that we make by just seeing someone. Also, expect that people from Latin or Latinx, Hispanic origin, they do not consider themselves smokers. For the same reason I mentioned at the beginning, that these people may be smoking less than 10 cigarettes a day, they smoke only on the weekends when they drink, then they do not consider them a smoker. So instead of asking, are you a smoker, yes or no, either asking or having that in your form, it's better to ask, do you smoke, or how much do you smoke, or tell me about your smoking history. So let's change our phrasing to be able to capture these people behaviors instead of labeling their behavior. Also consider the typical patterns of use during screening. as mentioned, let's don't assume that the quantity they smoke or the frequency they smoke. Let's just ask. And noticing that they're going to talk about probably social smoking or occasional smoking. That could be part of their background, and that they smoke less quantity, as I mentioned before. Another important point is that for a lot, or at least a considerable number of Latinos, Latinas, the first cigarette in the morning is not within the first 30 minutes. Smoking during the first 30 minutes from awakening is an indicator of dependence that is very known in the general population. But if we define dependence for Latinos based on that criteria, we may be saying that a lot of Latinos do not have a dependence to tobacco because they do not smoke right after they wake up. Some of them do, but a lot of them do not. So let's be careful about how we define dependence in this population, because their level of dependence can be described, it can be shown in a different way, and it could be more social smoking than something else, or it could be emotional. There could be other factors, but that criteria about smoking the first 30 minutes is not that common. Also, common triggers are use of coffee, use of alcohol. So these triggers are, again, not unique to Latinos, but also very common in Latinos. Something to highlight for Spanish speakers in particular is to consider the different words people use to refer to the tobacco products, and if possible, even using pictures to identify those. So we should not make assumptions about how people name a specific tobacco product. And as easy as with the cigarettes. Cigarettes can be cigarrillos or cigarros. For Puerto Ricans, for example, they're cigarrillos, which is very similar to the cigarillo in terms of spelling, but it's not the same. It's a different cigarillo in English is not the cigarrillo for some Hispanics. The same with cigarro. For Mexicans, cigarette is cigarro, but for Puerto Ricans, cigarro is a cigar. So you see what I am trying to say, right? The vocabulary can be different or is different for different sub-national groups of Hispanics. And it's important that we know that we are talking about the same thing with the person when we are making this assessment, that we are on the same page. And also take into consideration that these people may have not sought help before. Maybe you're the first person they talk about this with. So talking about their past history, what they have tried before, how did they try to quit, if they tried to quit, it's also important part of the assessment. In terms of the intervention, we need to start with health education about the addictive nature of the smoking from a biopsychosocial perspective. Also along with the role of medication and nicotine replacement therapy. Basically, as I mentioned, what is the role of nicotine? It's important to let people know, not only Hispanics, anyone, but with this particular group, it's very salient, that nicotine is an important component of the cigarettes, or traditional cigarettes. It has an impact on your brain. It has changes in your brain, and that is part of why this is so difficult for you to quit. Is not only because you do not have willpower or because you have a dirty habit. So it's important to help them rephrase and reframe their habits and their tobacco use. Also highlight and acknowledge the psychosocial stressors, the cultural factors that are influencing their quitting process, and why receiving medication will help and make sense to help them quit, because there's a biological part of this addiction. So connecting those dots for the person is really important. And let's notice that Latinos are a group that are very respectful of authority, including medical professionals, right? And healthcare professionals in general. So they're gonna take the doctor, the nurse, and different people in the medical field, they're gonna take their word very seriously. but it's important that we give them the whole information because they need to understand also why they are giving the instructions that are being given. Examine the role of the family and the peers. I know we know about the term familismo and how important is the family for this community, but it's important not to make assumptions of how much family involvement they want in a session or an assessment. They may want their family to come and they may want everybody in the room and they want everybody to know about what I'm doing. That could be the case of some of them. Other people, particularly females, they may be hiding their tobacco use and maybe a secret for a lot of them, and maybe people in their family do not even know they smoke. So assuming they want their family involved could be overstatement and could be wrong. So we need to identify what is the actual social support they have and what is the desired social support they have, or what's the social support they need, they want, and what actually they count on. So we can capitalize on that in the treatment. No surprise, important to examine the sources of stress related to the contextual factors, explore the acculturation process, where they are in that, how much social support they have, if they have family here in the States or other family is abroad, and if they have family abroad, how frequent they talk to them, how is their relationship with them, how, if they are experiencing any discrimination circumstances, or how they receive those situations, if there's perceived discrimination, right? It does not matter if it exists or not. At the end, if the person perceives that they're being discriminated, that by itself is going to have an impact on them. So we are not here to debate if they experience that or not, it's how they perceive that discrimination and feeling alienated an outside, like as an outsider, and the financial burden of the that they may have also. And with this, important probably to throw out there that helping them calculate how much money they will save if they quit smoking, how much money they will save on cigarettes, and putting that in very concrete terms could be one of the intervention strategies. Also, strengthen the motivation based on values, family, health, religion, spirituality. Sometimes we have an oversight about how some of these people may rely on religion and spirituality as a motivation to quit. And in terms of the family, also notice that some of these folks may be more motivated to quit because of the health issues that their smoking is going to cause or could cause on their partners, on their children, or their grandchildren. They may be more motivated to quit because of health issues for their family than to themselves. So focusing on you have to quit for yourself, for your health, may have a lower impact than trying to reframe that as stopping smoking to be a role model for the grandchildren or for the health of their family in general. So let's capitalize on the values to help increase and strengthen motivation. Again, for Spanish speakers, also the wording, it's important here in the treatment section because there are different words for different subnational groups or even within the same country. Cravings, for example, does not have only one translation. It could be antojo, could be ganas. Ganas is like very casual word. People that are in the addiction field may call it urgencias. So it could be different vocabulary. Also the patch. The patch is called parcho for Puerto Ricans, parche in Mexico and other places in Latin America. So let's see how the person referred to different terminology within the tobacco-related literature. And then to start closing here, other cultural considerations that came from our own research that we just finished recently. was through a qualitative study among Spanish prefer men and women both, but we analyzed the data for Latinas, and we found some recurrent themes that are in sync or just reiterate some of the findings that I have shared with you already about the acculturative stress was very salient. Also, shame and stigma. There was a lot of privacy, a lot of secrecy about smoking. So there's a lot of shame and stigma. And we need to recognize that when people like addressing the topic of smoking, because people could hide that information just because they feel they're gonna be judged because of their behavior. And it was very interesting, the conflicting role of familismo, right? Familismo for us in the Latin community is just it's not only that your family is important, because family is important for a lot of people, but it's when part of your decision-making process are done in a collective manner. And sometimes the boundaries between your family and yourself are very lax and too flexible, that could cause people stress, because yes, you count on your family, or you expect to count on your family for a lot of things, including, you know, recovering from a sickness or helping to stop smoking. But at the same time, even they can support and they're expected to support, but at the same time, they can be the same, they can also be the source of stress, because of that support that your family is also expecting from you, create additional demands that people have to deal with. So I found very interesting that conflicting role of familismo, and it's important that we take that into consideration, because it's may not always be a protective factor. Also, as we mentioned before, existing support or lack thereof, let's take that into account. Consider the family members' awareness about individual smoking status, and do not assume that they know, or everybody knows, or even that someone knows. Maybe nobody knows that they smoke, and that the stress that causes, like hiding that and being in that secrecy all the time, could be like getting free from that could be a motivator to quit if we get to that information from the person. And also very interesting that many of our participants felt comfortable or prefer the use of both Spanish and English. So assuming that the person has to choose one language, it may not always be true. Of course, everybody may have a preferred language, but even people that are Spanish speakers will throw in a few words in English to really capture what they want, or the other way around. So to the extent possible, if there's a bilingual person in the team that can navigate that bilingualism with the person, that would be a great asset to the team. So that's all I have. I have here the references in case people want to take a look at some of the actual papers or presentations that support the content of this presentation. Also, we have some additional resources here. The Taking Texas Tobacco Free website has materials both in English and Spanish. The National Institute of Health have a website that has information and also guidelines and guide to help people quit. The North American Quitline Consortium is the helpline to help people quit smoking and receive counseling over the phone. It's in different languages and including Spanish. And also another resource is the Si de Texto, which is a text-based program that was developed for another colleague or by another colleague that might be available still for Latinx people. And well, thank you very much for your attention and attending the presentation. I will like to ask that people take a few moments, just 1 minute of your time, to complete the evaluation of the presentation. We are doing this with all the presentations we're putting together. It takes like 1 minute of your time, and it will help us in developing other materials that are going to be useful for the population. Thank you very much for your attention, and I wish you the best in your treatment and helping us improve the gap and decrease the gap and the inequities among this population. Thank you.